Are you happy for me to make a start, Kate and Suzanne?
Yep.
Okay. Welcome, everyone. Make a start because we have a lot of content to get through this evening, and we want to make sure that we can cover as much as possible. Welcome to Supporting Adolescents in General Practice, Engaging Adolescents in Sexual Health Consultations, STI Screening and Mandatory Reporting Requirements. My name is Sam Reid. My pronouns are she and her, and I'm the Head of Education Services at Sexual Health Victoria. Before we start this evening, I'd like to just acknowledge our country. Suzanne's going to bring up the slide. Thanks so much. And I'd like to just acknowledge the traditional custodians of the land on which our work takes place. We're Wurundjeri Woi-wurrung people, the Bunurong people, and the Wathaurong people, and we pay our respects to elders past and present, as well as paying our respects to any Aboriginal and Torres Strait Islander people with us in the session today. So just a little bit of housekeeping before we start. All attendees are muted when they come in. Please keep your microphone on mute and ask any questions via the chat function. This session is being recorded. See that after the session. Please ensure you join the session using the name that you registered with so we can mark your attendance. We're not able to issue those certificates in CPD if we can't confirm your attendance, so thanks for that. Slide, and then just a few instructions about how to change your name in the Zoom meeting. So you can see you can click on participants. If you're using the app, click on your name or computer, hover over your name and click on the three dots. Click on rename, and then you're able to change your name and press done. So I'm delighted to introduce you to our two wonderful speakers this evening. Dr. Suzanne Pearson, she, her, is a GP and senior medical educator who brings her enthusiasm for education and training to health professionals. She's a fellow of the Royal Australian Colleges of General Practitioners and has a graduate certificate in clinical teaching. Suzanne coordinates the Family Planning Alliance Australia's National Certificate in Reproductive and Sexual Health for Doctors course and Implanon NXT training. She's authored articles such as LARC, New Evidence to Guide Clinical Practice, which was published in the RACGP's Australian Journal of General Practice. Joining Suzanne tonight is Dr. Kate Robertson. She, her, is also a GP and is a medical educator. She's a fellow of the Royal Australian College of General Practitioners and has a diploma in child health and diploma in obstetrics and gynecology. Kate has worked in various rural and metropolitan healthcare settings, and she uses this experience to help tailor learning to the participants' needs, with the overall aim of helping people to receive equitable sexual and reproductive healthcare throughout Australia. And it's my privilege to now hand over to Dr. Suzanne Pearson.
Thank you so much. Thanks, Sam. It's nice to be presenting this with Kate, and of course a huge thanks to the PHN for their amazing support of this session as well. So we're focusing on adolescents in general practice and how you can support and engage them in sexual health consultations, STI screening and mandatory reporting requirements. So just before we go into our first sort of area, I just wanted to let you know a little bit about Sexual Health Victoria. We used to be called Family Planning Victoria a few years ago, but we've renamed. And so we are a statewide independent charity. We focus on reproductive and sexual health care, education and advocacy. And our two sites are at Box Hill and also in the Melbourne CBD on Elizabeth Street. And so we have clinical sites there, and we also provide lots of clinical education and training. Our courses for doctors are RACGP accredited. We also provide lots of clinical education training for nurses and midwives and other health professionals. So just a little example of some of the things that we provide: IUD insertion training, Implanon training, cervical screening training for nurses. As Sam mentioned, we run a national certificate course in reproductive and sexual health for doctors, and we've got a similar course for nurses, which is called the Comprehensive Sexual and Reproductive Health course. We've got lots of online courses as well. We've got mini audits and a new course called Menopause Management and Mini Audits. So that's one to look out for a different age group to what we're covering today. We've got a web link there. So in the session today, we're looking at covering the learning outcomes that you can see there. So first of all, engaging adolescents in sexual health consultations with confidence. Applying trauma-informed communication and STI screening practices in these consultations, and explaining mandatory reporting obligations following disclosures of sexual abuse. So we do want to make the point that this presentation is for training and educational and general information purposes and shouldn't be relied on or substituted for legal, medical or other professional advice. So obviously with your own individual cases, you may need to seek your own advice, but we hope that this will be a useful educational session for you. So now I'd like to point you in the direction of Health Pathways, which is a really fabulous online resource for you to go to find, clinical information, referral pathways and things like that. So they're really great evidence-based resources and can help in making sure that we're pretty consistent in the way that we provide care around the state. So it's also got really good referral pathways. So I'm just going to show you some slides from the Health Pathways that are relevant to what we're going to be talking about today. So if you have a look on the left of the screen there, you can see that we've got sexual health checks and sexual health referrals highlighted there. So they might be some really great areas to be looking at. And as you can see highlighted down the bottom right of your screen, you can also send feedback to Health Pathways. So if you've got comments or questions, then that's the place to go looking for those. So if we're looking at doing a sexual health check, you can see that there's various links here that can be useful in terms of how to conduct a sexual health check. It'll tell you a bit about specific populations as well. So that's relevant to today because we're talking about adolescents. And as well as that, there's links to management options as well. So whether that's for sexual health matters, whether it's for things like child safety, mandatory reporting, or education training, or other topics related to sexual health as well. So there's lots of information there. Here's some key links for you in terms of those relevant pathways. And another thing that this slide tells us is that you can actually look at health pathways for CPD as well. So that's a good attractive option for us all as GPs. Here's a snapshot of the tips and resources for adolescent health. Again, just a little bit about CPD for health pathways. And lastly, here's a slide which is really useful if you haven't actually signed up for Health Pathways. You can do so using the QR code there as well. It's very straightforward to sign up and you'll be on straight away. So that's good to know. So let's jump into the first part of this presentation. We're going to be looking at adolescence and sex. So just to set the picture, we thought it would be interesting to just present a little bit of information from the Australian Secondary Students and Sexual Health Survey. So for this survey, which large survey, there's data which was collected around 2021. And it actually surveyed almost 7,000 students who were of the age range of 14 to 18. A large variety of questions relating to sex and sexuality. And there's also will be a new up-to-date survey coming out relatively soon because a 2024 data set has being collected and is being analysed. But today we're presenting from the 2021, which is published. So this is an interesting slide showing the change over time of sexual activity. So with this survey, they're collecting data from students in Year 10 and Year 12 and have been doing so since 1992. And so we can see here a comparison. You can see on the left, you've got the Year 10s, and on the right, you've got the Year 12s. So we can see that for people who have been sexually active, and that's defined in this survey as having vaginal or anal sex, who have ever had those types of sex, that for Year 10s, it's around 43% of those people surveyed, and for Year 12s, it's almost 70%. So what we can see there is that this is a really relevant topic, because for these age adolescents, that sexual activity is relatively common. And also you can see from this slide that there has been a bit of an increase, and with the 2021 survey showing higher rates of sexual activity than previous years. And now this slide here is looking at condom usage. So this is obviously relevant when it comes to protective behaviours around sexual health, be it preventing pregnancy or STIs. And so this data is looking at whether a condom was available and whether a condom was used when the person had their last sexual experience. So that we can see in the 2021 survey that 75% had a condom available, but only 49.3% actually used the condom. So there is a bit of a widening of that gap between available and usage over time. So I think that's, an interesting point to note, and realising that condom usage is, people are using condoms and having them available, but certainly for every time that they're having sex. And this is a great thing to know for us as healthcare professionals, is that we can see there's a really high rate of trust for GPs in providing accurate information. So 78% of those young people surveyed have that trust, but actually quite a lot less of them have spoken with a GP at least once about sexual health advice. And very small amount, only 3% have spoken with a GP several times or more in the past year about sexual health. So I think one of the messages we can take from this slide is that GPs and I think we could say other related health professionals are a trusted source of information, and the onus can be on us to actually proactively offer to discuss sexual health topics with adolescents. So now I'm going to pass over to Kate, who's going to talk with us about adolescent consultations.
No worries. So adolescent consultations can be challenging for a number of reasons, and adolescents can face some additional barriers to accessing healthcare. So some of those that people can be concerned about privacy and confidentiality. So it's really important to explain that, and we'll get into that in a bit more detail later. Other issues can be location. So often if a clinic's not easy to find, or there's not receptions that are obvious, signs at reception that are obvious, or near public transport, it can be an extra challenge. Often clinics are open sort of only in school hours. So if you're having a large amount of young people that your clinic is servicing, it may be useful to think about opening hours. Adolescents can often find the keeping appointments and making appointments a bit challenging. Cost considerations can also be a big barrier to young people, and other things like the gender of the practitioner, or sometimes feeling like that a practitioner that they go to with their family and concerned about that can be an issue. Young people can often feel embarrassed about talking about sensitive issues. So I think if the clinician also has some embarrassment, that can kind of transfer as well. So it's really important to be open in your discussions about sexual health with young people. And the other barrier can be things like Medicare. So often young people don't understand the intricacies of Medicare, which can be challenging for everyone. And certainly in terms of maybe not having access to their own card, or understanding what their parents may or may not be able to see on their health record, can be really important. So in further detail around Medicare, young people can actually access their own Medicare card at 15 years of age or younger than 15 in some special circumstances. So if you do have adolescents that you're seeing that are concerned about that, you can direct them to Services Australia to look at getting their own Medicare card. However, even if they are on their parents' Medicare card, a parent or carer cannot access information of any person aged 14 or over who's listed on the family card without written consent of that person, and that includes my health record. So a young person can also be listed on 2 cards at one time. They can have the family card as well as their own card with a different number. So we're going to have a case example, and we'll come back to Stella throughout the presentation tonight. So Stella is 15. She uses she, her pronouns. She attends with her mum. Her mother says that she's come in to discuss Stella's periods. So the mother gives most of the history with Stella using lots of liners and pads and thinks she might be iron deficient from having heavy periods. So you can see that in this example, you could go down one track in terms of managing the periods, but it's really important to get young people alone without their parent, because there may be some history that they don't volunteer whilst their parent's in the room. So in this example, so with Stella with her mum in the room, states she's coming to discuss her periods. However, on explaining that you usually see young people alone for at least part of the consultation, without her mum in the room, Stella tells you that actually her periods are usually manageable and regular. She has a boyfriend of 3 months and is sexually active, and she's been using condoms some of the time. She's using pads and liners every day because she's noticed an increase in vaginal discharge over the last 2 months, and she's worried that she might have an STI. So you can see that the whole scenario can really change upon getting an accurate history with the young person on their own. So often young people do come in accompanied by a parent or guardian. So it's really important to greet the young person first because they're the patient, and I often sort of, if there's 2 seats in the room, often the adolescent will go to the one further away, and I try and encourage them to come to the closer one as they're the patient. So really important to greet them first and ask them to introduce you to the person that they're there with. And I often ask if they want to be seen alone or with their parent. And if they do come into the consultation with the parent, I normally do explain to both the young person and the parent that during the consultation, it's really important that we see young people alone, at least for part of the consultation. Sometimes I give the young person the option of whether they would like to do that first or last. And then when you have the young person alone, it's really important to explain confidentiality and its exceptions, which we will get into later. And explain that you do see young people for a range of health issues, including concerns related to sexual health, contraception, drug and alcohol use, and mental health. So sometimes it's really good to get into the practice of doing this routinely, because it may be that a person has come to see you for something totally unrelated to sexual health, but I think that if you can let them know that you're open to seeing these things, it may be that they don't take you up on that offer that time, but maybe further down the track they will, and know that you're a trusted source that they can go to. So before inviting the parent back in, it's really important to clarify the issues to be discussed and what they may or may not be wanting to disclose to the parent, and just to be really careful of what you ask when a parent is present, because you may not get an accurate answer for one, and you may also expose the young person to risk if they are giving an answer that their parent's not happy with. So a good tool to speak with young people is the HEADS assessment. And this assessment is really designed around asking some less invasive questions at the start and then getting down into some more personal questions. So we often start with home, education or employment. Every time I look at this one, it gets extended to lots of different acronyms, but it's really important to think there's lots of different things that can be going on. So eating, exercise, sometimes bullying at school, activities young people do outside of school, and then moving on to some more sensitive topics like drugs, sex, suicide or self-harm, and social media. So if we move on to the next slide, there's some good examples of how to phrase some of these questions. So usually some really easy questions like who lives with you at home, I often say things like, you know, and does everyone get along? And that often allows the young person to explore that a little bit more. And then I often move into questions about education and school, and bearing in mind that school can be a really good and positive place for some young people, but some young people not so much. So I often sort of ask questions around along the lines of, you know, what's your favourite subject at school, which for some people garners a big response, and then things like what's your least favourite subject at school, which often garners a bigger response, and can help you build a bit of rapport with that young person. When you are moving on to questions around alcohol and sex, a good way to kind of approach those is to normalise it. So I often will say, look, I see a lot of young people who are starting to experiment with alcohol or sex. Is that something that you or your friends do? And that might garner a response about friends in the first instance, and then you could ask something along the lines of, is that something that you've tried? When you are asking about sex and sexual activity, it's really important not to make assumptions. So asking questions along the lines of have you been sexually active is a really good opening question, but then following on from that with other open questions such as what is the gender or genders of your sexual partners can be really helpful. And so some of these questions just again helping to really normalise them. So saying I see a lot of young people when I ask questions about their sexual health, is that okay? So asking that permission and signposting it can be really helpful. As we said, not to presume the gender of sexual partners. So we know that 10% of young people don't identify as exclusively heterosexual. Asking about contraception, including condom use and withdrawal, and asking about if they know how to get condoms and if they're easily available. Asking if they know how to access emergency contraception if needed, which is over the counter at pharmacies in Australia. And it may be pertinent to explore consent to sex and relationships. In terms of confidentiality, it's important to note that we have a legal and ethical duty to provide confidentiality to all of our patients, including adolescents. There's not a clearly defined law for adolescents, but it's reasonable to consider that all information from an adolescent is confidential unless there's an exception applying. And to really think carefully about breaching confidentiality, particularly if no exception applies, because you're really likely to lose the trust of that young person and they're unlikely to return to you for medical care if you do breach that confidentiality. So the exceptions would be that if the person consents to disclosure to a third party, and that consent must be given voluntarily and without coercion. If you need to disclose it to other health professionals necessary to treat the patient, and noting that that confidentiality extends to other health professionals as well. If a disclosure is in the best interests of the patient, and this is a bit of an uncertain area as it's not been examined by Australian law, disclosure to prevent a real risk of serious harm, such as a risk of death, would probably be viewed as acceptable by the court. In terms of risks of someone harming them, we'll discuss that in a bit more detail later. There is disclosure in public interest, so serious risk to other people, and a legal duty to disclose, for example, if required in court, or a disclosure required by statute, so for example, mandatory reporting. So how to practically put this into a nice little spiel to tell your young people? There's lots of different ways to do it. My personal preference, I say to young people, look, really important, everything that we say here is confidential between ourselves. There's a couple of times that I might need to break confidentiality, but I'd always tell you about. And those would be if I'm worried you're going to hurt yourself, if I'm worried you're going to hurt someone else, if I'm worried someone's hurting you, or if sex is occurring outside of the law. So there's a few ways to put that, but often young people, especially the more that you see them and the more that you discuss this, they'll understand these concepts. So moving on to STI screening, which as we see is a really common reason that young people may present to clinics. So what is a sexually transmitted infection? It's an infection that's passed through oral, vaginal, or anal sexual practices, or close oral, genital, or anal contact. And they can be split up into a few different categories. So we have bacterial infections, which are chlamydia, gonorrhea, mycoplasma genitalium, and syphilis. We have viral causes, which are things like herpes simplex virus, which is not always sexually transmitted, but can be, HPV or human papillomavirus, hepatitis A, B, and C, which can sometimes be spread during sex, but again, not always, HIV and Mpox or monkeypox as it's previously known. Then there's others which we probably see less common, or some of them less commonly in Victoria, but things like trichomonas, pubic lice, or other sexually transmitted infections, things like Shigella, Mycoplasma, molluscum contagiosum, and bacterial vaginosis, which until recently we didn't really consider a sexually transmitted infection, but that has, is an evolving area. So a key guideline for screening and management is the Australian STI guidelines, which go through a lot of detail in terms of what to test if you have a positive result, what to treat with, and what kind of partner notification and follow-up is required. So a standard STI screen refers to patients that are asymptomatic, so coming in with no symptoms at all. And what we would offer as a standard asymptomatic screen would be a test for chlamydia and gonorrhea. And that can either be done as a urine sample, or for people with a vagina, it can be done as a self-collected vaginal swab. So not necessary to have a clinician collected. Some people prefer that, but you can instruct people on doing a self-collected swab. And as part of an asymptomatic screen, we would also test for syphilis and HIV, and hepatitis B if the person hasn't had a full course of immunisation or is at a higher risk. And we would generally offer STI screening annually or more frequently depending on the risk. For men who have sex with men, we do extend that screening somewhat. So for chlamydia and gonorrhea, we would check 3 sites. So we would check a urine sample as a first pass urine. We would also check a throat swab, which can be clinician collected or self-collected, and an anal swab, which again can be clinician collected or self-collected. And blood tests for syphilis, HIV, hepatitis A and B, unless they've been vaccinated. And we would offer this screening 3 monthly. There are some good resources available to instruct people on how to do self-collect. And lots of young people will find this more acceptable than obviously having a clinician collect a sample. So these ones are from New South Wales, and we have the link later in the presentation, but they can be handy if you're seeing lots of young people to put up in your bathrooms, just as a way to show young people how to do these swabs. And from a practical point of view, often if you are, because time is often a challenge, especially with seeing adolescents, because you're often needing to do the consult twice almost with the parent there and with not. So if you are sending them to the lab, just writing on the form self-collect, which means that then the pathology person won't be confused or trying to collect samples, can be a really helpful tip.
Yeah, and another little tip I'll share is that if you're sending a patient to the bathroom for the anal swab, is that they can wet the tip of the swab with water to make it more comfortable as well. So that can just make it a little bit more acceptable for your patients.
So what we don't offer as part of a standard STI screen is herpes serology. It's a really unhelpful test because it doesn't tell you where or when the person might have been exposed to herpes. So it can often be really distressing if people get a positive result, but it can often be that they've had a cold sore as a child. So we don't routinely do that one. Likewise, hepatitis C, we wouldn't do unless there were risks, for example, injecting drug use or tattoos not done in Australia or in an authorised tattoo shop. And we don't routinely screen for Mycoplasma genitalium unless they have symptoms, and we wouldn't routinely do a monkeypox swab unless there was an ulcerated lesion that we were wanting to swab. Should a result come back positive, the overarching principles for treatment of positive STI results are to treat the infection, so either with antibiotics or antivirals, offer contact tracing to the young person, and DHHS notification pending which STI is found, which can be generally quite easily done as an online form, and then talk to them about follow-up. So some of the STIs require a test of cure, some of them require a test of reinfection, and it's just generally a good time to give some health advice about condom use and safe sex to young people. So we'll go through some case scenarios and we'll just get you to type in the chat what you think. So Tom is an 18-year-old gay male who presents for STI screening. His last test was 6 months ago, which was HIV negative. He's been vaccinated for hepatitis A and B. What testing do you recommend? So A, HIV and syphilis serology. B, HIV and syphilis serology, urine chlamydia and gonorrhea PCR. Or C, HIV and syphilis serology, urine, throat and anal chlamydia and gonorrhea PCR. Yep. So some responses in the chat coming through for C, which is correct. So because Tom's a male who has sex with men, we're looking to do a more extensive STI screen. Excellent. And our next case is coming up.
Sorry, I need to. Sorry, Kate, I was not concentrating.
Oh, good. So Safia is a 16-year-old female who presents for STI screening. She's never had an STI test before and she's up to date with routine vaccinations. What testing do you recommend? So A, urine or vaginal swab for chlamydia and gonorrhea. B, HIV and syphilis serology and a urine or vaginal swab for chlamydia and gonorrhea. Or C, HIV and syphilis serology, urine or vaginal, throat and anal chlamydia swab. So what do we think for Safia in the chat? So it does depend a little bit on her sexual history. So we would potentially ask some more questions, but generally speaking, we would say B for Safia. So HIV and syphilis serology and a urine or vaginal chlamydia swab, chlamydia and gonorrhea swab.
Yes, I think that's a key difference that people have identified in the chat, is that for someone who is not a man who has having sex with men, we don't usually include throat and anal swabs as an STI screening test, but we obviously would if they had symptoms or potentially additional risks.
Excellent.
Great. I think this is back to me now, isn't it, Kate?
Yep.
Lovely. Okay, so now we're going to start exploring some of the issues around sex and the law with regards to our adolescent patients. So just a little reminder here that there are various sections in health pathways that will be useful to us in these situations. And so we've highlighted here one around disclosure by a child or young person of sexual abuse. So that's going to have lots of really key practice points and links and resources. So we're actually going to come back to Stella now. So as you probably remember, Stella is our 15-year-old who had presented with her mum, and we had a chat with Stella on her own. So we know that Stella, well, she tells us that she has a boyfriend. They've been together for about 3 months and she's sexually active. And she's using condoms some of the time, but not all of the time. So Stella was concerned about an STI. If we remember, she felt that she had an increased vaginal discharge. And so we organised for Stella to have STI testing. And so that included testing for chlamydia and gonorrhea, which could be done either with first pass urine or vaginal swab. So in this case, we've got a positive result for chlamydia. Chlamydia is a common STI, and it is something that particularly for people under the age of 30 has fairly high prevalence for people that are sexually active. So the issues that we would like to think about with Stella now, and we'll explore through some more information now, is how are we able to decide if Stella can consent to treatment? And also, on a related note, how could we decide if Stella can consent to contraception, being a young person who's sexually active and using condoms some of the time, but obviously is quite significant. So to consider these points, we need to look at what the legal situation is for treatment for young people. So this is what we call consent to medical treatment, or the competent minor. So we know that the age of legal majority in Australia is 18 years. And so knowing that, thinking about people that are under the age of 18 years, there's no assumption that those under 18 are able to consent or not able to consent to medical treatment. And there's no younger age limit defined by law. So in this situation, the common law is applying. And what that states is that a young person who's less than 18 might be able to give informed consent, and the health practitioner must consider the nature of the treatment proposed and the ability of the young person to understand the treatment. So in Australia, our law is guided by a substantive case from the UK law, and this is called Gillick's case. So we can refer to this as Gillick competent or a mature minor. And this case was looking at the legal capacity of minors to consent to medical treatment. And so with the Gillick case and mature minor, it says that a young person under the age of 18 years is legally competent to consent to medical treatment if they're capable of understanding the nature and consequences of that treatment. So we refer to fulfilling those requirements, which is around the capability of understanding the nature and consequences of the treatment, as Gillick competent or a mature minor. So the specific case was around contraception, but this can potentially be used to consider other situations for young people and treatment as well. So when it comes to young people, how do we as health practitioners assess competency? So it really is up to us to form our own opinion about the patient's intelligence and understanding. How would we go about that? We need to consider a few different factors. So age would be one of those factors. So as you can imagine, the closer that someone gets to 18, the stronger that case is that they would, naturally be able to form, have the required intelligence and understanding to consent to treatment. As well as that, the level of schooling can be helpful. So if they're, able to achieve, educational levels, then that helps us to know that they're able to understand the information that's being provided to them. We can use their general maturity in speech and bearing to help us with that. So having a conversation, doing things like doing that heads assessment will be really useful in this sort of context. As well as at the level of independence from parents, and this does vary quite widely with young people. And so again, doing the heads assessment and asking some questions about things like home, education and activities can help us to get an idea about whether that young person is able to is already, doing things on their own, making decisions without their parents' direct involvement at times. And also the young person's ability to express their wishes. So are they actually pretty clear on, what they're looking for, why they're looking for that, and does that have some logic behind it? This is all going to be really helpful at allowing you to form an opinion that the patient has sufficient intelligence and understanding to consent to medical treatment. So we do need to be satisfied that the young person's understanding what the treatment's for. So I guess if we're looking at the case of Stella, we'd be looking at antibiotic treatment for the chlamydia infection, what other treatment options are available, if there are any. What are the risks versus the benefits of the treatment? any possible side effects of the treatment, and that's obviously going to vary depending on what it is that you're looking at, and also the consequences of not treating. So that's important as well. So it's not just about the treatment, but it's also about, you know, what happens if we don't actually provide this treatment for the young person. And the sort of documentation that we would do in our medical record would be a heads assessment or notes of a similar nature to us having had that sort of you know, level of conversation with the young people, that we can understand a bit about their general intelligence and understanding. We can document in the notes that the young person has been assessed by us as a mature minor or as a GILIC competent person. So that would be worth including in your records. And also a discussion about whether the young person feels able to discuss these matters with their parent or guardian or another appropriate adult. The Fraser guidelines have actually sort of come about through the GILIC case that we've discussed earlier. And in this case, the Fraser guidelines were specifically written to go with the ruling that relates to contraception and sexual health. So when it comes to consent for treatment, the Fraser guidelines tell us that to establish that the practitioner needs to establish that the young person understands the advice and the relevant clinical information. We need to believe that the young person is likely to begin or continue to have sex with or without contraception. Believe that the young person's physical or mental health or both are likely to suffer if we don't provide the contraception. So I guess that could be, for instance, that we feel that a potential unintended pregnancy would put their health at risk. And also to believe that it's in the young person's best interest to prescribe contraception and to maintain the confidentiality. Another key part of the Fraser guidelines is that it does indicate that there should be a discussion with the young person about the potential benefits of discussing the treatment with the young person's parent and or guardian. However, what that doesn't include that the young person has to discuss it with their parent or guardian if we consider them to be a mature minor and they have good reasons to not discuss it with their parent or guardian, then that's okay. The fact that we've had a conversation around that will fulfill the Fraser guidelines. As we can imagine, for some young people, it can be quite positive to actually have a conversation with a parent or a guardian or another trusted adult. So for instance, that could be an aunt. So that could be a positive thing. And sometimes if we say, well, what would mum say? You know, what do you think mum's reaction would be if you were to discuss this with them? That can be quite helpful. But for some young people, it's really not going to be in their best interest to discuss that with a parent or guardian. And so as long as that you've had the conversation and you're clear on the reasons why they're not going to be able to discuss it, then you can still fulfill the requirements under the Fraser guidelines and as a mature minor. So I might just pause to see if there are any particular questions that we need to cover relating to that. Is there anything in the chat that we need to cover at the moment?
There was more just some general questions about, so someone asking if they have a young person who's not got any symptoms and caught an STI from a recent casual partner who's asymptomatic, how they know who they got the infection from if they've had multiple partners over the last 12 months. So it's sort of answered in the chat about generally speaking, the rule of thumb is around the contact tracing guidelines. So for gonorrhea being 2 months and chlamydia being 6 months.
6 months, yeah.
And yeah, and then there was a follow-up question saying, you know, is that all it could be? And no is the short answer. Like there's a possibility that it's longer than that. So, but those are the recommendations around contact tracing. So, you know, this person may not know, and certainly if they're having ongoing sex with partners from that time frame, they may wish to let them know, and there are resources like Let Them Know, for which they can anonymously partner notify you via text or email. That will just send the person a message saying someone you've been in contact with has tested positive to these, and encouraging them to get tested. So they may never figure out where they got it from, is the short answer.
Yeah, absolutely. Yeah. And Let Them Know is a good website to be aware of, that if there's a young person who's not feeling able to do that contact tracing themselves, then they can use Let Them Know, or they can even, you can do it with them, where you can actually, with the young person, put the contact details into Let Them Know as well. So that's another possibility for contact tracing. It is really important to do contact tracing for many reasons, but obviously for your patient's health, because if they're having sex with that person again, then they may just reacquire the infection, which can obviously be a negative for their health. So with Stella, let's have a think now about how we can explore if the sex that she's having at the moment is consensual, and also if mandatory reporting is required for Stella. So let's have a look at these questions now. So thinking about unwanted sex, we've got some information again from the 7th National Survey of Australian secondary students. So in the survey, it showed that almost 40% of all sexually active Year 10 to 12 students reported that they have had sex that they didn't want at some time of their lives. So, you know, that's obviously, you know, a high number. But if we break that down into gender, we can see that the rates are higher for females and for trans and non-binary people. So these are people who have higher you know, risk and higher experiences of unwanted sex. And in the survey they ask what the reason for the sex that they didn't want to have were. And so there's a variety of reasons. We can see that the most common one reported was that the young person had received verbal pressure to have sex. So there was that sense of pressure to go along with something that they really weren't wanting to do. Around 40% were worried about negative outcomes of not having sex. And then there's also others that were physically forced to have sex, and then others that were affected by drugs or alcohol, and that was affecting their ability to consent as well. So looking at age and consent to sex and the law in Victoria now. So if someone is under the age of 12, it is always a criminal offence for anyone to have sex with that person. So it doesn't matter what any of the circumstances are, that's always going to be illegal. If the young person is aged between 12 and 15, then that person can't have sex with someone who is more than 2 years older than the young person. So that means if you've got someone who is 13 and there's someone who's 16 having sex with them, then that would be illegal. Although there is a potential legal defence if that person honestly believed that there was a gap of less than 24 months of age between the two people. If the young person is age 16 or 17, then they may consent to sex with an older person as long as they were not under the care or supervision of that older person. So there's a variety of people that would be considered to be supervising the young person, and so some examples is that it could include a teacher or a youth worker or a coach, a sporting coach. So they would be examples of where it would actually be considered illegal for a 16 or 17-year-old to have sex with that older person. and over the age of 18 is legal, I should mention as well. So it's important as well to be considering for these situations for 12 and over that the sex must be consensual. We know that consensual sex between peers will rarely result in legal prosecutions. So if there are peers, so similar aged young people having sex together, then that's very unlikely to lead to legal proceedings. We know that sexual exploration with mutual agreement, so with consent between same or similar age peers, is a legal defence in Victoria. So the law isn't so concerned about two young people engaging in sexual exploration or activity, but they are concerned when there's someone who has that age gap or is in a position of power over the young person. And keep in mind, of course, that under the age of 12, then it's always a criminal offence. And even if the young person in theory consents, that's not going to be legal at all. So when we're talking about consent, we can think about the consent continuum. So consent isn't perhaps as simple as just a yes or a no, but certainly there are different levels where there is less consent involved that we need to be concerned about with young people. So when we're talking about consent, ideally we're looking for enthusiastic consent, and that means that both people want to have sex and can express that they want to have sex. So that's the ideal, is enthusiastic consent. Compliance, however, means that the compliant person is just going along with the idea of sex because they don't really know how to say no, or they think it's just easier to go along with it rather than saying no. So this is obviously starting to get into slightly concerning territory here. Pressure refers to where one person is talking the other person into it and making them feel too uncomfortable to say no. Coercion is where there's the outcome of not having sex is worse than having it. And then right down the bottom, we've got force, which is where someone's being forced or having sex, taking sex against without someone's permission. And so that would be, clearly classified as rape and is a criminal offence. And we do know that most rapes are committed by someone that the victim knows. And it's really important that whatever the situation, that it's not the victim's fault that's occurring. It's the fault of the person who's doing that, or the perpetrator of against that young person. We have affirmative consent laws in Victoria, and what that means that if someone wants to engage in a sexual act with another person, they must actively gain consent rather than rely on the other person to give their consent. So that means that the onus is on people to actually check that their sexual partner is actually actively consenting rather than just being compliant. So if a sexual assault is alleged, the burden of proof of consent is actually the responsibility of the alleged perpetrator with these affirmative consent laws, rather than the alleged victim survivor. So the perpetrator would need to be proving what they actually did to confirm that the person was consenting to sexual activity. The affirmative consent laws also include stealthing, which is a term that refers to non-consensual condom removal as a sexual offence. So that could be, for instance, someone who agrees to use a condom and then doesn't use it without checking or informing the person and checking for consent, checking that there is consent to that sexual activity without a condom, or it could be removal of the condom during a sexual act without gaining consent. So that would be referred to as stealthing. And the affirmative consent laws also affirms the person's right to withdraw consent at any time. And I think this is particularly important for young people who will be inexperienced and perhaps lacking in confidence in this area for some young people. So some information that, you know, we can share if relevant to young people is that if someone consents to one sexual act, it doesn't mean they've consented to another sexual act. And for us, we need to know that if someone doesn't feel safe or respected about withdrawing their consent, then it's not really consensual sex. So that's part of consent, is that someone needs to be able to say no when they're wanting to say no. So when we're thinking about unwanted sex, it's really pertinent to be considering trauma and chronic trauma for our patients. Unfortunately, we do know that sexual assault is very common. So about 1 in 5 Australian women have experienced sexual violence since the age of 15. And also intimate partner violence. I'm sure you'll know this as healthcare professionals is a very common thing in our community, so that a full-time GP would be seeing 5 women per week who've experienced intimate partner violence in the last 12 months, and 1 in 3 who've experienced that in their lifetime. And of course, the RSCGP White Book is such a key resource for us when we're looking at intimate partner violence. So in our practices, we can know that not all patients will necessarily disclose a past history of sexual assault or intimate partner violence to us. But what is really key for us is thinking about safety for our patients and making our patients feel as safe as possible. So in some ways, we're ensuring that we're taking a bit of a universal precaution approach, so that we assume that perhaps anyone who presents to us may have experienced these sorts of traumas in their life, and that we consider that our practice across the board for all of our patients would be sensitive practice, considering that the person may have been exposed to these sorts of traumas and therefore have, you know, sort of responses that might relate to those traumas. So some principles around trauma-informed care for us would be thinking about patient-centred care. So thinking about our patients, realising that they may have experienced trauma and trying not to re-traumatise that person. So trying to do no harm where we possibly can. We know that for anyone who's experienced these types of traumas, that those experiences have actually involved a loss of safety, a loss of autonomy for that person. And so for that person, being in a safe environment, being respected, having a sense of control can be quite empowering and is validating for our patients in terms of, you know, helping them with their recovery. So making sure that we're very patient-centred in all of our work is something that's really a trauma-informed principle. If someone does disclose to us, for instance, a past history of trauma, be that sexual abuse or intimate partner violence of any sort, then we've got a key role that we can validate that. So we listen and we tell the person that we've heard what they've told us. It's really important that everyone deserves to feel safe in their relationships, in their homes, and so to acknowledge that it's actually brave of that person to disclose, and it shows that you're actually quite trusted as a clinician. So that's a really good sign that you've developed some good rapport with that person often. And in addition, we can also try and avoid practices that might inadvertently re-traumatise. So when we're thinking about trauma-informed care for things like examinations of patients, we'll be thinking about what sort of examinations might be traumatising for our patients. So that might be things like intimate examinations. You know, we're talking about sexual health today, so thinking about examining genitals, doing vaginal examinations, etc. And so checking in with the patient, explaining why we're wanting to offer the examinations that we are, the purpose of that, what would be involved, and making sure that they have the ability to control that, so they can say that they want to stop at any time. They can, you know, be in control of that process is really important. And if they're not ready for that examination, if it's not the right time for them, then generally it's not going to be urgent, and we can find other ways to help that patient. And as Kate's mentioned earlier, something even as simple as offering a self-collected swab rather than a clinician-collected swab could be something that might be relevant for that person if they're choosing not to have an examination. So let's look at mandatory reporting now. So this in Victoria falls under the Children, Youth and Families Act. And mandatory reporting means that certain professionals, and that includes doctors and nurses, but also a range of other professionals like psychologists, social workers, youth workers and teachers, are required to report to the Department of Families, Fairness and Health cases of child physical or sexual abuse. So we've highlighted that it's around physical and sexual abuse that we're mandated to report in Victoria. So if we become aware of those in the course of our employment. And the relevant age group that mandatory reporting applies to is young people under the age of 17. So that means anyone who's 16 years and under that it applies to, but not those who are 17, 18 and older. Our responsibility is to, we're mandated to report harm, but not to report simply underage sex. So you'll remember that we spoke before about the fact that there are laws around underage sex, and if that sex is within the law potentially and is consensual and you're not concerned about the child's physical or sexual harm, then you may not need to mandate. And we'll look at some examples in a moment. Mandatory reporting also requires that we make the report as soon as possible. So it doesn't mean putting it off for a fortnight. It means doing it today, pretty much. And in addition to that, we're actually able to discuss any concerns informally with the Child Protection Officer. So if you're not sure whether something falls under mandatory reporting, it actually is a good idea, or can be a really good idea, to still contact Child Protection and run it by them to see whether that is something that either falls under mandatory reporting or is something that they may already know about or be helpful for them to know about. We've put on the slide here various phone numbers and also the web link for you to access this information. So during normal working hours, you need to ring the number that relates to the area that you're in, whether that's north, south, east or west. But there's also an after hours central number, which is available 24 hours. So that would be, for instance, after 5 p.m. on a weekday, but also on the weekends. So let's look at some scenarios now. So I'd like you to consider whether mandatory reporting is required for these situations. So first of all, let's look at Ben. So he's age 16 and tells you that his stepfather has hit him on 2 occasions and that he's fearful that he will be hurt again if his stepfather becomes angry. So I'd like you to have a think about the information about mandatory reporting. And what do you think? Does this constitute a risk of harm for a young person under the age of 17? And that harm would be physical or sexual. So do you think that this would require mandatory reporting? Great, I'm seeing some people saying yes in the chat. So thank you for giving this one a go. That's really great. And yes, I agree with you. So Ben is under the age of 17 and he is at risk of harm from physical abuse. And we can see in this situation that he doesn't have the protective factors of a parent who's able to protect them from harm. In this case, it looks like the harm is actually coming from someone who has that parental responsibility for Ben. So that would constitute mandatory reporting and you would call Child Protection. Let's look at scenario 2. This is Mia, who's age 19, and she tells you that her boyfriend has pressured her into types of sexual activity that she doesn't feel comfortable with. So again, thinking about those criteria for mandatory reporting, what do you think? Do you think that Mia falls under the mandatory reporting obligations that we have as healthcare professionals? Give this one a go in the chat as well. Great, thank you. I'm loving the answer in the chat there. So you've given us a no, but then a little bit more information as well. So yeah, I would agree with you that it doesn't technically fall under mandatory reporting because she's over the age of 16, so mandatory reporting doesn't apply. But of course, we're concerned that she's being pressured into sexual activity. And so, you know, we can have a discussion with Mia around you know, the affirmative consent laws. We can have a discussion with Mia around, you know, perhaps seeing what she feels that she can do about this situation. So supporting her, giving her information, and seeing whether she might like to be linked in with other services, perhaps. There's a question in the chat about, do we need to report rape if it involves adults? We don't need to report rape. That is up to the adult to decide if they're wanting to report that to police, or if they're wanting to have forensic investigations. So no, that doesn't fall under our obligation to report. So mandatory reporting is only for young people. So thanks for that question. Let's look at scenario 3. Jess is age 15. She's having consensual sex with her boyfriend who's aged 16 years. So do you think that this would fall under mandatory reporting? Great, so we're getting some no's in the chat there. So of course Jess is 15, so she is the relevant age, but she is having consensual sex with a boyfriend who's a peer, so he's of a similar age. And so from that information, we don't think it probably would be mandatory reporting unless we find out something else that makes us feel that she is at risk of harm because of this, in which case, of course, we would reconsider whether it was mandatory reporting. But from this basic information, it doesn't probably meet the criteria. Let's now look at Ellie, who's age 15, and she's having sex with her tennis coach who's aged 20 years. So what do we think about Ellie? Yeah, so we would need to report for Ellie. So she's under 17 and she is having sex with someone who's older in a supervisory or carer role. So it's around the power imbalance that this one means that we would need to do mandatory reporting. So even if Ellie says to you that she wants to have sex, that from her point of view it is consensual, it still is considered mandatory reporting because of the risk of harm of sexual abuse from that older person who's in a position of power over her. So I think there's a question in the chat about what if she's not using condoms? Is that considered a risk of harm? So I think you're asking about case 3, Jess. In its own right, it wouldn't constitute mandatory reporting. So I agree with you that there is some risk to her health, but it's not the sort of risk of harm. I think the scenario there would be that you would obviously want to engage Jess, develop some rapport, and have some discussion with her around, you know, what she can, what her options are around accessing condoms, using condoms. Does she feel that she can discuss that with her partner? So in its own right, it wouldn't be a mandatory reporting situation. And in fact, to be honest, would be a very common situation. So,
Suzanne, can I just interrupt with one more question, if
yeah,
that's okay,
please.
before you move on to failure to disclose? There's just another question in the chat around 44% for females who did not want to have sex but felt pressured is very high. Is this a problem, and what is being done to address this?
It is high, isn't it? Now that's not that all of their sex was unwanted. The question in that survey was, have ever had unwanted sex? But it is very high, and it's very it's quite in many ways a shocking statistic, and obviously not ideal. So what sort of things are being done to address that? So I think that there are many sort of programs in place, supports in place. And I'm actually wondering if I might call back on you, Sam, because I know that you do a lot of work in this area around education for young people in schools and in the community. Is that something that you'd be happy to speak to briefly, Sam?
Yeah, sure. I think, yes, I think I would absolutely say that this is good evidence for why we need comprehensive relationships and sexuality education that is funded across every state and territory and in every education setting, including schools and other spaces as well, when we know that those rates are so high. So I think there has been national support, including mandatory consent education. Advocates like Chanel Contos and so on. So there has been a sort of national call for more consent education, but of course, some of us might argue that that's not comprehensive enough. So we think that sexual health, relationships, consent education should go together and start early in an age and stage appropriate way.
Yeah, thanks, Sam. So that's so important. And I guess for us as healthcare practitioners, developing a bit of confidence with being able to discuss consent with our patients is helpful as well. So there's a lot of talk about consent in the media and in schools and things like that. So if you raise the issue of consent, it's likely to be something that young people and their parents have come across, and are likely to see that as a positive if you raise that with them. So thanks for that particular question. I think it is such an important area for us to be thinking about, and for our society as a whole. So we've started to get our head around mandatory reporting, and that's a really key thing for us. But we're going to just slightly complicate things a little bit now by also introducing you to some other legislation that relates to sex for adults in Victoria. So let's have a look at what's called failure to disclose legislation. This came about after a Royal Commission that was looking into sexual abuse. And so we have this failure to disclose legislation. So what it says is that for any adult in Victoria, so this is not just for us as healthcare professionals, it's actually for any adult in Victoria, if we form a reasonable belief that a sexual offence has been committed by an adult against a child who's under 16, so that means who's 15 and under, then that adult has an obligation to report that information to police. So what we're talking about here is an offence by an adult against a child is what needs to be reported by any adult. Now, interestingly, and I think something that helps us with our consultations is that registered medical practitioners are actually exempt from this legislation or from this reporting requirement if they become aware of a sexual offence during a consultation with the victim. So if we are seeing the young person, so that's a child under the age of 16, and we are a registered medical practitioner, then if that young person doesn't wish us to report, then we're exempt and we don't need to under this legislation. However, if we're a registered medical practitioner and we see the older person who's committing this offence, then we would need to report. So they can't ask us not to, then it would be something that we would need to. Under this legislation, it's only medical practitioners that are exempt, and nurses and other adults, which would include medical students, are not exempt. So that means that there is a difference with the different professional groups. And if you'd like to look at more at failure to disclose, then we've got a link there for you. So we thought we would just look at a case study now that might just help to explain this a little bit more. So this is Morgan. Morgan's 15 and she's attending our clinic for advice on contraception. And during the consultation, she discloses to you that her partner, called Tom, is age 19. So obviously we're thinking about some of our obligations. Do we need to report under mandatory reporting, or do we need to report under failure to disclose? So they'll be the things that we'll be thinking about here. So we've got 4 different questions for us to consider. First of all, Morgan's 15, she's having sex with Tom, who's 19. Does this need to be reported under mandatory reporting legislation? And what else would you need to know to make that decision? So we're talking about mandatory reporting at this stage. We're not talking about failure to disclose. Do we need to report? So remember, the things for mandatory reporting would be, is the person 16 or under? So yes, she is. Is the young person at risk of harm, of sexual or physical abuse in this situation? So that's really the question that you're answering here. And of course, I haven't given you much detail. All I've given you is the ages. So what do people think? We've got someone who's thinking yes.
Yeah, there's a couple of yeses in the chat.
A couple of yeses in the chat. Okay. So generally, I would actually probably say that it's unlikely that mandatory reporting would be required in this situation, based just on the ages of the people. So yes, we know that Morgan's 15, but her partner is a bit older. But remember, it's not just the age for Morgan's 15, so it's not just about the age of her partner. It's actually about whether the partner is in a position of power over her. And the information that we have is that we don't know that there is. So perhaps that would be a question that we would want to know. So mandatory reporting wouldn't necessarily be required unless the child's in needing protection, so that they've suffered harm or is likely to suffer significant harm. And in addition to that, that the child's parent or guardian couldn't protect them from harm. So although we don't know for sure, we might need to ask some more questions. It's likely that this wouldn't fall under mandatory reporting unless we discover that there is that risk of harm. Let's consider question 2. If we have a doctor, so if we're the doctor and we're seeing the patient, do we need to report this under failure to disclose legislation? So in this case, Morgan's 15, so that is within the age group of failure to disclose. And her partner, Tom, is 19, which is over 18, so that also meets the conditions. But remember, we're the doctor and we're seeing the young person. So what do you think? Do you think that this would be something that falls clearly under failure to disclose? Okay, yeah, so for this one, probably not. So as a doctor, we can check with the young person. If they're not wanting us to report under failure to disclose, then we don't need to, because doctors are exempt. So, I mean, of course, this is a Victorian legislation, so it only applies to those practicing in Victoria. So let's think about the same question, but this time we're the nurse and we're seeing the patient, and do we need to report under failure to disclose legislation? So what do you think about that? So remember, we're the nurse, we're seeing Morgan, who's 15, and she's told us that her partner is age 19. So in this case, we would need to report because nurses are not exempt from the failure to disclose legislation. There's a question in the chat asking why are doctors exempt? And that's a really good question. So I think that there are good reasons why doctors are exempt, and it's to support doctors in conducting sexual health consultations with young people and being able to provide that sort of medical advice and support that we would need to. I think probably more of the question is why aren't nurses exempt? So it would be really helpful if nurses were exempt as well, because they're often doing very similar work in supporting young people. So yeah, so I think that's probably where there's some challenges within that legislation. And let's look at scenario or question 4. So if the doctor or nurse saw Tom as the patient, so now we're not seeing Morgan, we've actually seen Tom as our patient. And as part of the consultation, he told us that his sexual partner, Morgan, is age 15. Do we need to report that under failure to disclose? So in this situation, we're seeing the adult who's disclosed that they're having sex with a young person under the age of 16. What do you think? Would that be under failure to disclose? Yes, it would. Yeah, that's right. So in this case, there's no exemption for doctors. So there would be a need to disclose. And with this legislation, we would need to report to police. So generally, it would be reporting to the local police station. That can feel quite scary to do. But in fact, in reality, generally, a report under failure to disclose won't actually result in any prosecutions. So I think it's just we need to be aware that that is the legislation that we would need to comply with. If we're going to report, then it would be generally a good approach to inform the patient that is our responsibility and that that's what we need to do. Of course, that does risk developing an ongoing therapeutic relation with that patient, but it is something that we are obligated to do. I don't know whether Sam, if you're happy to chime in again, I know that Sam, you've had experience as a clinic nurse in reporting under failure to disclose. Would you be happy just to briefly let us know what your experience has been as a reporter?
Yeah, I think for me in this case, it was about accessing termination of pregnancy. And I think, the patient was really trusting in seeking that confidential healthcare. So it was really challenging. And I think what helped was what Kate talked about earlier about establishing those, parameters around confidentiality really early on. So then it comes as less of a surprise when you're saying, actually, I believe that this could be sex that's occurring outside of the law. So I think, yeah, just referencing back to that's really important at the start, and being really honest and upfront with the patient about what you need to do as well. So I think what I was able to do when I contacted the police, I was able to clearly outline what was actually happening, which in this instance, the patient was very clear that this was consensual sex for them, even though it was outside of the law. So that was a helpful distinction to explain. I think the other thing that is really helpful is to lean into your medical colleagues for support. So I was able to talk to our medical director about that and seek support straight away. So I think that's really critical as well when you're dealing with these sorts of things that happen, because you can often feel that you're breaking the trust of your patients, but ultimately we're directed to do this. So it can feel super challenging to contact the police as opposed to child protection, but I think advocating, for the patient the best that you can was a really good sort of path to take, in my experience. And unfortunately, I think the negative outcome was that I don't believe that the patient did come back, but we were they were younger, and we were able to refer them to, actually, in this instance it was referring them to a tertiary hospital setting for their termination service.
Yeah, thanks, Sam. So as we get to the conclusion, just some take-home messages. So as Sam's alluded to, these situations can feel quite isolating. And remember, you don't have to do this alone. So do access support. So whether that's through colleagues, through other organisations that can support you, whether it's through your medical indemnity to run things by, then that's going to be really helpful. These situations are not always black and white. As we can see, often you're needing to find out a little bit more, you're needing to check in on some details. And so that's something that will, help you to work through these situations. Remember that you can always call and ask to have a hypothetical discussion with child protection. So if you're not quite sure, you want to find out, does this fall under mandatory reporting? Is there any other advice or other information that can be helpful for you in this situation? Child protection is there to support those conversations. And also we do need to be thoughtful about our actions, but ultimately what we're really looking at doing is protecting young people. So thinking about those principles that we've discussed tonight can go a long way for that. So we've come to the end where we've got time for questions. So I might stop sharing the slide set now and open up to see if there are either any questions in the chat that people would like to post now, or if there are any questions that we haven't been able to thoroughly answer in the chat.
I think we've managed to answer most things as they've come up along the way. So, but if folks have anything else, please feel free to add them now.
That's great. Excellent. I should actually also, I will go back to just sharing those slides for a moment, because I did realise that there is another slide that I do want to share with you. So just bear with me while I go back to that. So please do keep posting questions if there's anything, but just to conclude the session, we'd just like to ask you to please share your feedback on the session. There is a QR code up on the screen now, and you'll also receive the slides and resources discussed during the session, as well as the certificate and RACGP CPD hours as well within the 30 days. And there's some links there with regards to further education provided by the Northwest Metro PHN, as well as information about the recording as well. So if you've got your phone, you can scan that QR code now. Are there any other questions there, Sam?
No, I don't think so.
Okay, well, thanks everyone so much for coming, and thank you so much to the PHN for hosting and supporting this really, really, great topic that we've been really pleased to share with you all.